afternoon, everyone. Welcome to our monthly CME on DocQuity. Today, we have our regular speakers, Dr. Ong, on the topic. It's a very interesting topic about pelvic pain, but focusing on gynae-related pelvic pain. Okay, and also how do we actually diagnose, what is the diagnostic strategy when it comes to pelvic pain, which is gynae related. Before we start, let me introduce our speakers. Dr. Ong Hean Choon, he is the consultant, obstetrician and gynecologist, and also menopause consultant at Taman Desa, KMI Taman Desa Medical Center, Kuala Lumpur. He is also a medical legal consultant since 1993. Dr. Ong has received over 110 international recognized awards, and he has also published 84 scientific papers in locals, regionals, and international journals. He has also published 9 booklets, 2 of them on menopause, and his main interests are gynecological endocrinology, including menopause, contraceptions, DUB, endometriosis, cervical dysplasias, CIN, as well as, of course, in colposcopy. Without much ado, Doctor, I pass the floor to you.
Okay, thank you very much, Louis, for that introduction. I'm sorry for my voice quality. I'm still recovering from a bout of laryngitis, and I hope that I think you can hear me quite well because my voice is almost 80% okay.
Yeah, it's fine.
So I'd like to get started on the topic. My assignment this afternoon, anyway, good afternoon to all of you who are at the moment listening in, would be actually gynae-related pelvic pain. And I'm just trying to mention to you all a diagnostic strategy as to how we can actually dissect this pain and then come to some form of an idea about what the poor woman is suffering from. That's me. I'm currently, as what Louis says, a consultant OAG at KMI Taman Desa Medical Center. I'm also a menopause consultant and a colposcopist and CIN consultant. Okay. If you look at the diagrammatic representation of what are the possible causes of pelvic pain in a woman, you can see that actually there are many causes, many. Okay. Now, for the purpose of today's discussion, I have chosen to exclude urinary system problems, bowel system problems, pregnancy states, and bone and joint problems. So I'll principally concentrate on the gynae issues, namely menstrual cramps, for example, ovulation pain, endometriosis, the pelvic congestion syndrome, uterine fibroids, ovarian cysts and its complications, and also pelvic inflammatory disease. So we will actually concentrate on all these and hope to finish by the time allocated to us. In the proper assessment of pain, you may want to look at actually basically the nature of the pain. You want to know the location. For example, is it suprapubic, just above the pubic bone, or is it at the sides, maybe in the RIF or in the LIF? You would like to know the duration as to how long the woman has been suffering from the pain. And this gives you an idea of whether the pain is of a acute nature or also of a chronic nature. And as far as the other part of the nature of the pain, is the pain sharp in nature or is it crampy? Because it denotes different issues, okay? Okay, now in gynae, we also want to know its relationship to the periods and also importantly, relationship to sexual activity in a woman who has sexual activity. Then we also would like to assess for associated symptoms of the pain, how's the period flow, whether there's any accompanying vaginal discharge, any urinary complaints related to the pain, any bowel complaints, and perhaps maybe any fever or not in the particular woman. And our clinical examination should include an abdominal examination, which all of you doctors can do very easily. As far as a gynae examination is concerned, we would actually advise a vaginal bi-manual examination if it can be done for the patient. If it cannot be done, for example, in virgin girls, then we can still do a rectal examination. And those of us who have been trained, we can do a rectal bi-manual examination. So there is no excuse to say that you cannot do a vaginal examination in a virgin girl. Okay, let us start with some conditions so that I can give you some guide as to how you can actually dissect the pain. Ovulation pain, very common in women, coming to you pressing one side of the abdomen like that. Now, ovulation pain is usually one-sided because the ovaries ovulate one ovary at a time. It is typically mid-cycle or around the mid-cycle. In most of the patients, it is usually mild in severity. Okay, and then the accompanying symptoms, many of them do complain of slight vaginal staining. And they may just tell you maybe a few hours, only one day or something like that, or 2 days, something like that. And some of them will complain to you that they actually have watery vaginal discharge, which is one of the commonest things that happens. So the pain usually lasts for 1 day, at the most 2 days. Now, if you do an abdominal examination or any pelvic examination, you will find that there's no significant physical signs on abdominal or vaginal examination. Maybe you might notice some slight tenderness in the abdomen, and that's all you will get from the patient. We always advise our patients that if you think you have ovulation pain, if it's very severe, there's accompanying vomiting or diarrhea, or you have some trouble breathing, which is very, very uncommon anyway, you should see a doctor and get it properly evaluated. The next common thing that happens in women is actually dysmenorrhea. The term dysmenorrhea means menstrual cramps. So the pain is crampy in nature. And there is two types mainly, primary and secondary. Okay. Now, primary means that the pain starts from the menarche. The moment the woman has her periods, she already starts having the pain. Secondary means that actually there is a period of time where there's no pain, and after that there is pain. So this is secondary. And once a woman has secondary dysmenorrhea, it signals actually that there must be some problem in the reproductive tract of the woman. So we have to seriously look for this. Now, let me give you a guideline as to, let's say P stands for periods and the X stands for actually the pain. All right. Now, in this situation here, the pain is intramenstrual. And in most cases where there's intramenstrual pain, the pain is usually spasmodic in nature. What does this mean? It means that actually it is mainly of uterine origin. Now, if you look at this, therefore, the two common conditions would be primary dysmenorrhea or perhaps uterine fibroids or adenomyosis. So it localizes the profile to the uterus. I repeat, intramenstrual spasmodic crampy pains. Now, pain can occur before the onset of period, and this would be called premenstrual pains. Commonly due to pelvic congestion, which I'll describe in a moment, or perhaps the presence of pelvic inflammatory disease, or in short, in gynae, we call it PID. Now, sometimes the pain actually occurs only after the period, post-menstrual pain. And with this sort of pain, it is commonly due to PID. So that helps us to have some clues as to what is the possible source of the pain in this woman. Now, there are some women who have pain before the period, during the periods, and after the periods. So here we have a condition where there is premenstrual, intramenstrual, and postmenstrual pains. And actually, in standard teaching, usually it is due to endometriosis. Now, I'm quite sure you all know what is endometriosis, so I don't have to describe endometriosis in full. Right. Now, pelvic congestion, it is not that uncommon, but it is really related to the presence of varicosities around the ovary and the paniform venous plexus in the pelvis, in this area. And many people believe that there is a faulty valve in the ovarian veins, therefore leading to the varicosities in the ovarian veins. Now, in patients like this, usually the pain is usually more dull, and you remember the pain, the so-called pain dysmenorrhea is premenstrual. There may be a slight abdominal distension. The abdomen is usually soft, and if you do a vaginal examination, there are no significant findings. So when the period comes and the congestion is relieved, the pain will go off. That is the way to diagnose this condition. Now we talk about uterine fibroids. Now, uterine fibroids, you know uterine fibroids, okay? And we know that actually when there are significant number of uterine fibroids, the woman can have spasmodic dysmenorrhea. So that is a form of pelvic pain. And mainly due to actually what we call intramural fibroids, and especially with submucous fibroids. Now, this is a subserous fibroid. Usually, there's hardly any pain, but for intramural ones or the submucous ones, then there can be significant pain, especially with the submucous fibroids. Now, the other symptoms associated with fibroids which will help you will be presence of pressure symptoms in the lower abdomen, sometimes the presence of heavy periods, especially with submucous fibroids, and because of the enlarged uterus pressing on the bladder, there can be urinary symptoms. There can be some abdominal distension actually, and some patients even tell you, I feel a mass in my lower abdomen. So this gives you an indication that actually you are dealing with a fibroid. Occasionally, you can have sharp pain in a fibroid. Now, when a sharp pain occurs in a non-pregnant state, then we have to suspect the possibility of what we call a degeneration change. And the most common degeneration in non-pregnant fibroids will be hyaline degeneration. This can give rise to very sharp pain. This is a fibroid showing degeneration. You can see that the whorl-like appearance and the general sort of a whorl-like firm nature is lost. There are areas of degeneration within the fibroid substance. So associated actually symptoms on abdominal examination could be you may feel abdominal mass, you may not. And if you do a vaginal examination, then you will feel that the uterine body is enlarged and very often irregular. So that gives you a clue that you are now dealing with a uterine fibroid. It's quite simple actually if you just use a proper diagnostic strategy. Okay, we now go to the next common condition, ovarian cyst. Most ovarian cysts are asymptomatic. They are usually discovered during routine ultrasound scanning of the pelvis, but some of them may cause abdominal discomfort, dull type of pain in the lower abdomen or one side. There could be slight abdominal distension, and in some cases, when it's big enough, then you may be able to feel a mass. So even the patient sometimes can feel a mass. By my experience, most of the patients feel that actually they're growing obese. So when they feel that their lower abdomen is getting bigger, they think they're putting on weight, but actually there is a mass there because the mass is usually quite soft and not that simple to feel. Now, sometimes you can get acute pain in the ovarian cyst. Now, when that happens, usually it's on one side and the pain is sharp. Like on one side, the pain is sharp. And usually this is due to either bleeding inside the cyst, maybe an infection, which is not so common. And the worst that can happen is there may be a rupture. Now, if you look for abdominal signs, if there is a rupture, especially look for abdominal signs of tenderness, guarding, rigidity, and if there is bleeding from the cyst into the peritoneal cavity, there will be signs of peritonism. So this will give you an idea about there was a cyst and perhaps there can be a rupture, but even bleeding can also lead to peritonism without rupture. This can also happen. Occasionally, you will feel that the pain in the cyst is not really very sharp, but it is of a twisting nature. And the patient may be able to describe to you, look, doctor, I have this twisting pain in my side there, you know, and I'm told I have an ovarian cyst. Then you can actually be able to make a diagnosis as possibly there may be torsion or the cyst has twisted. And especially so if the pain is accompanied by vomiting. Now in this sort of scenario, then you have to consider there may be torsion of the cyst, and these abdominal signs will still persist together with this. There is a very common condition we face with in gynecology called a ruptured corpus luteum cyst. You're quite aware that the corpus luteum usually forms after ovulation, and a cyst may form, and sometimes the cyst may rupture. And when this thing happens, the pain is acute, one-sided. There may be abdominal signs or there may not be any abdominal signs at all. And usually the time it occurs is within about 1 week after ovulation. Actually, this can be very easily diagnosed on an ultrasound scan because you can really see a ruptured corpus luteum cyst very clearly on the ultrasound. I move on now to the next condition, which is very common too. That is pelvic endometriosis. You can see all the spots there, the scarring and the spots. Okay. All these are pictures of pelvic endometriosis. In women with pelvic endometriosis, pain can be a very significant symptom. Some of them have no pain at all, and they may be discovered, especially when they go for investigations for infertility, and then a diagnostic laparoscopy is done where it's found. But in the symptomatic patients, pain is a significant symptom. The pain can be menstrual, as I mentioned to you just now, in pre, intra, and post-menstrual pain pattern. It can be also intermenstrual, that means in between the period, right? Okay. There can be pain on defecation during the period time because the nodules are on the surface of the rectum. There can be pain on urination, especially when there are actually seedlings on the bladder. And it can also cause pain during intercourse for the couple, especially for the woman, or we call it dyspareunia, especially when there is what we call rectovaginal endometriosis. So pain is a very, very significant symptom in women with endometriosis. Usually there are no significant abdominal signs, but if you do a pelvic examination, say for example a bimanual VE, you may be able to feel nodules in the pouch of Douglas. It is not so difficult to feel it actually, it's quite simple if you are trained enough or you're experienced enough. And these may be tender nodules. In virgin girls, you can still do a rectal examination and you can feel the nodules in front of you. And in fact, it is even more clear than doing a vaginal examination. So in patients, please do not exclude doing a rectal examination. Now, the other condition I'd like to mention is PID, pelvic inflammatory disease. Usually you will find that PID, there are two types. One, acute. In these women, there is acute pain. The pain is usually bilateral because usually if one tube is inflamed, the other tube is also inflamed. So basically the pain is bilateral, and they may be the onset of fever in such women. If you examine the abdomen, it's usually tender, both sides, the RIF and the LIF. There can be guarding, and with the infection spreading into the peritoneal cavity, there can be signs of peritonism. If you do a vaginal examination, if you can do it in that woman, we do a digital examination first. We do what we call a cervical excitation test. That means we hold the cervical stump between our two fingers, and then you move the cervix. And if the test is positive, then you will find that actually the pain, there's tenderness at both sides. Okay, so that's called a positive cervical excitation test. Now, of course, if you do a bimanual examination, you may feel pelvic tenderness in the pelvis. So this gives you the clue that actually you're dealing with an acute PID. Now, sometimes the pelvic infection can be actually chronic. So in chronic pain, the pain can be acute upon chronic. That means the pain occurs over a long period of time. Most of the time, it is maybe mild and crampy, but there are acute episodes in between causing severe pain. So we call that a acute upon chronic PID and acute upon chronic pain. And usually the pain is bilateral. Fever is not usually a feature unless during the acute episodes there is a significant amount of infection. Now in the vaginal examination digitally, usually in the chronic cases, the cervical excitation test is negative. You don't find it unless you are dealing with acute upon chronic episode. There may be some pelvic tenderness, but not as bad as actually we see with those patients with acute PID. So therefore, this could be a symptom, a sign, but not necessary. So I like to just mention that please, in a gynae patient where you have to do your clinical examination, never forget a rectal examination, because as you can see in the diagram, you can really do a very good biomanual examination with a rectal examination. You don't always have to do a vaginal biomanual examination. When things get complicated, you refer to a gynecologist, or most of the doctors I find in private practice, they do actually have access to ultrasound, pelvic ultrasound machine, and they have been trained to do bedside ultrasound scanning. Now, with a good practice with ultrasound scanning in the pelvis, you can actually make your diagnosis even more sharper, and you can really come to a good diagnostic conclusion. And of course, if you refer to a gynecologist, in some instances, we may have to do a diagnostic laparoscopy to further evaluate the pain and to really come to a final conclusion as to what we are dealing with in that particular woman. So basically, now I've tried my best to give you some diagnostic strategy and points as to how to evaluate all these various clinical conditions and come to some good diagnostic conclusion. And to be honest with you, many of the minor problems you can manage yourself in your clinics outside, but if those that you are not very familiar with or you are a bit concerned, please refer to your relevant gynecologist for further evaluation and diagnosis. So with that, I end my brief lecture on this topic about gynae-related pelvic pain and how you can develop a diagnostic strategy. Sorry about the spelling error here. And try to come to some reasonable conclusion. Thank you very much.
Thank you, Dr. Ong. Okay, let us start with the Q&A. Okay, there's one question here. I'd like to ask Dr. Ong, yeah? Usually, at what size of the ovarian cyst that will actually cause acute pelvic pain to a patient, based on your experience?
Based on my experience, any size.
Oh.
In fact, the very, very big ones don't usually cause pain. The smaller ones are the ones that usually cause a lot of pain, see, because they can expand, especially with bleeding and also with torsion. But the really big ones, no, very unlikely. But to answer the question, any size of cyst can cause pain.
Okay, all right. There's another question here. What would be a good analgesic for dysmenorrhea?
Okay, right. I hope no drug company is listening in.
No drugs company here.
Yeah. In gynecology, in my experience, if the dysmenorrhea is accompanied with heavy periods, I find that the best analgesic would be mefenamic acid. For example, Ponston, okay?
Okay.
Because mefenamic acid has been shown in research studies to not only reduce the pain, the pelvic pain of dysmenorrhea, and also to reduce the flow of the period. So actually it's got a double action. And therefore it's more effective for that sort of situation. Now, if you have a patient with dysmenorrhea but no heavy flow, that means normal flow, so any analgesic will do. But currently, actually, we find that actually Celebrex is more effective for such women. Celebrex. I think you all know Celebrex. Okay. Now, for Ponston or methylphenidate acid, you should use a dose of at least 500 milligrams 3 times a day. If you use a lower dose, it may not be so effective. Okay. And in my experience, for Celebrex, I use at least 400 milligrams twice a day. The 200 milligrams will hardly work for women with dysmenorrhea. So that will be my current practice.
Okay. Okay, we have another question. What is your treatment for acute PID?
Well, if I make a diagnosis of acute PID, which I can do clinically without anything else, I don't have to ultrasound the patient, or I don't have to do a laparoscopy or whatever it is. So I think once you make a diagnosis, you should give the patient an appropriate dose of a good antibiotic. Now, in my experience with gynae patients, it is very common for me to use 2 antibiotics together, meaning one will be in a standard broad spectrum antibiotic in combination with metronidazole or flagyl, because most of the other antibiotics may not deal with the gram-negative bacilli or the anaerobic bacteria in the pelvis. So if you combine the antibiotic with flagyl, you will get a very good, effective antibiotic for acute PID. And of course, for acute PID patients, you just take care of the pain. So depends on what analgesic you prefer. Up to you. I just use methylphenidate acid or Celebrex, and that's all. And then you just give a course of antibiotics for a reasonable period of time. My usual duration is at least 7 days, not 3 days or 2 days, 7 days, after which I will review the patient in my clinic, clinically. And that's what I'll do.
Okay. Now, this is another 2 question here. For teenager, can Ponston be used?
Absolutely, yes. You can use Ponston for teenagers. There's no contraindication. The only problem with methylphenidate acid is that actually, please ask a history of gastric pains, because those women with gastric problems, you have to be careful. And those with mild gastritis, for example, you have to warn them that actually they may feel a little bit woozy in their GI tract, especially with the use of Ponston. Other than that, there is no contraindication.
Okay, right. When does a uterine fibroid need to be operated on?
Good question. Okay. As a gynecological principle, when do we operate on the uterine fibroid? Firstly, if it is too big. Okay, what do I mean by too big? As a cutoff point in gynecology, anything more than 5 cm would be considered big. That's number 1. Number 2, if there are multiple, not only one, there may be few, multiple uterine fibroids. 3, if the fibroids are symptomatic, and symptomatic means usually either they cause pain or they cause heavy periods, then we would consider operation. So these are the 3 main things: the size of the fibroid, the multiplicity of the fibroids, and the symptomatic fibroids. Okay. Now, some people believe that fibroids may also actually be a factor in causing infertility. Of course, there are some studies which indicate that if you seriously think that the fibroid is the main cause of the infertility, removing the fibroid may improve fertility. But I always tell my patients, on the other hand, we are aware that the operation of removing fibroids, mammectomy, is a very, very actually important cause of pelvic adhesions. And therefore, instead of making the fertility better, it may make it worse. So therefore, in those type of patients, we have to really seriously counsel the patient and talk to her. But the three initial reasons I gave you would be the commonest reasons why doctors would actually operate: the size, the multiplicity, and the symptoms.
Okay, this is my, I have a question here, yeah, doctor. I did heard some gynecology, someone when GDoc consultant was saying that if, let's say, you have regular dysmenorrhea, and before you know that your periods is about to start, you will need to start any sort of, maybe constant first. Say you have the symptom of periods going to begin, let's say tomorrow. Then you're going to start so that you start the analgesic first, so that you stop all the receptors. What is your opinion of that?
No, I think that's a wise idea, because if you really feel that it's coming, you can always prevent it from occurring. Yes, I've advised many women like that, because if you use NSAIDs, for example, like that, you don't have to use it for a long time. You only need to use it for a few days. So it is sensible to start before the onset of severe pain, so that you don't get the severe pain. Yes, I would accept that.
Okay, all right. Okay, doctor. So, say for example, the GPs, because we have a lot of GPs in this meeting. If without ultrasound scanning in the clinics,
yes.
Okay, what is this so-called step-by-step? Because of course we're talking about based on gynecologists to say, right? So if it's a female patient comes at the doorstep, complain about pelvic pain. So what they should do, and like step-by-step, give some tips on that.
Well, I mean, the first thing is how severe is the pain that the woman is feeling, That's the first thing you do. If the patient is in very severe pain, and then you know that you have to try to alleviate the pain, that will be the first step to do. Okay, and then secondly, you look at the general condition of the patient. If she is really not well, and if you take her vital signs and she's not so good, then I think you should start to think about referring the patient out, not in your clinic. You don't deal with the patient in your clinic, you see. Now, if you have a patient with pain, not so severe, and then she comes to consult you, she looks well, then, as I mentioned just now, take a good history, do a proper examination of the patient, come to a conclusion as to what you're dealing with, and then if you feel that you can manage, which I know a lot of GPs can manage pelvic pain in some of the conditions I've just mentioned just now, you go ahead and treat her. See? You go ahead and treat the patient. And then you bring her back after about maybe 5 to 7 days and see how's the condition. If she's much, much better, thank you so much. If she's not much, much better, maybe continuation of the treatment can be done. Or if you are not comfortable handling the patient, then you refer to a gynecologist for further evaluation. And that's what I would do.
Okay. All right. I have no more questions from the floor, from both channels. Today we also have nurses on board, yeah? Okay, doctor, why not you just give your final advice to the GPs when come to this topic?
Well, I mean, we used to talk to our ED doctors a lot about this topic, because most of the ED doctors are faced with this problem of pelvic pain in women in the ED, emergency departments. And I think you should understand women a bit more mainly their gynecological conditions, because many doctors, although you are trained in the various disciplines of medicine, but I find in my experience, for a general practitioner or an ED doctor, their skill and knowledge about gynae conditions is terrible. I'll be frank with you. I don't think they are very adequate in handling, but I don't think you all should be frightened about handling a woman in pain, because there are so many conditions there that are quite mild in nature and not life-threatening. So you should learn how to assess them properly, like what I've already given you, a guideline, and then make a diagnosis and increase your knowledge about the gynae conditions. I don't have so much time to describe every condition in detail, but I've given you some hints about what to do. And I'm quite sure that most of you can handle the conditions, so that at least you attend to the patient on the spot, on site, relieve her pain first, and if she needs further treatment that you cannot handle, you refer to the appropriate doctors. And that's what I'll do. And that's the advice I'll give it to you, so that at least your doctor, your patient doesn't go away from your clinic still suffering. So relieve her pain, and then be humble and tell the patient that actually, okay, I think you have this gynae condition, and I don't think I can handle it for you. So I'll refer you to a proper gynecologist to sort it out for you later. But for the moment, I'll help you to relieve your pain. So that will be the first thing to do.
All right. Thank you, Doctor. Okay, I think we have no more questions from the floor. Then we're going to end it. Okay, thanks, Dr. Ong, for, as usual, a very comprehensive, very informative talk. As usual, I'm sure all of us are benefiting from it. Thanks, Dr. Ong, once again. So we shall end our session today. So yeah, just for everybody's knowledge, that we actually having a CME talk with Dr. Kwiti actually on monthly basis. So stay tuned for our next upcoming CME talk. Thank you very much. Thanks, Doctor.
It's my pleasure. Thank you very much.